Hello, good morning, everyone, or good day, or good afternoon, depending where you are now. So, good morning, good morning. Let's see here in the chat. Hi, okay, hello, everyone. So, first of all, I am Dr. Diana Mihai. I am president of the Romanian Society of Aesthetic Gynecology and as well international speaker and key opinion leader for different procedures, let's say like this. We are doing courses since the last 8 years, and this is where we have our seven international congress this year. Every year we do this in Bucharest, Romania, and participating all over the world as well. So I know that you are all over the world. I'm still waiting for some of our colleagues to enter. And until then, I will really appreciate if you would write in the chat, where are you from? Let's get to know each other for a couple of minutes. We have now here Dr. Raluca Hera as well. She's our chief committee for hormonal treatments, and we are organizing courses together in the last 5 years. So let's see. Wow, we have Hungary, we have Dubai, we have, let's see. Oh, so many messages. Let me find them again. Okay, one second. Okay, so Spain, North Macedonia, Jordan, Greece, London, Lebanon, Germany, Abu Dhabi, Azerbaijan, Romania, Sudan, Lebanon, Croatia, Turkey, Lithuania, Romania, Ukraine, Poland, Dubai, Austria, Bosnia-Herzegovina, Kosovo. Hello, everyone. Portugal, Montenegro, Greece, UK, Latvia. Oh my God, that is really great to have you all here. First of all, I want to congratulate you for being here because it's a lovely Sunday today, right? I don't know how the weather is in your country, but I think it's pretty much amazing everywhere. So you could have done anything else today, but I congratulate you that you are here to invest in yourself, in your to improve your knowledge and to help your patients. Actually, in the end, okay? So congratulations to you all. So we will have, let me explain a little about today. We will use two different things. We will use this chat to discuss about different aspects, and maybe Dr. Aluka will put some questions like I did just now. Slovenia, Saudi Arabia, Albania, yay, Bulgaria, great. And in the same time, we will have, you will see the Q&A. The Q&A, you will find it, it's a box with a circle and three dots there. Let's see if you find it. And if you click on that, it says more, you will find Q&A. Let's write their test to see if you find it. Oh, we have already a doctor that put her first question to be sure that we will respond to that. Okay, great. So, how this the first doctor, Dr. Wana, put it, it's very good. So, if you have any questions, any cases that you want to discuss at the end, please write as many details about the patient. For example, like the age is very important, and in the same time, the comorbidities or personal history or family history is very important. Okay, and then what is her complaint? So what is the question? You need to put a question as well. Okay. So the age, if she is in menopause or not in menopause, if she still has menstrual cycle or not, if it's regular or not regular, and the age when she stopped having her period, for example, comorbidities, personal history, family history, if it's relevant, and her symptoms, and what is her problem, and what is your question, okay? And it will go like this. First, we will have Dr. Aluka's presentation in the first part of the webinar. And then we will introduce a surprise for you. And then we will have the Q&A, okay? So stay until the end because at the end we will have the clinical cases, discussions, and we will take them in order. So as soon as you put that, as soon you'll get your answer. Okay? I think everything is clear. So I think we can get started now after the introduction. I'm very happy to have here Dr. Raluca Hera. She's an international expert in hormones, peptides, Dutch test, and all of this longevity and functional gynecology. So we are working together in the last years, and every doctor that worked with us was very happy, and they said that they learned so many things. So I hope that you will have the same opinion after we finish this. Yes, Dr. Raluca, please.
Hello, hello. Can everybody hear me and see me? Can you hear me and see me?
Just write in the
Diana?
chat if it's okay. Okay, yes, well.
So everybody hearing and seeing. Thank you. Hello, everyone. Thank you all for being here. I hope you enjoy this Sunday. And today I want to speak about HRT in a way that is practical, structured, and clinically responsible, as with all our webinars on this theme and with all our courses of this theme. So I will share my screen first, and just let me know if everything is fine. So please let me know if you can see my screen so that we can already start. Let me know if the screen, yes, you can see the screen. Perfect. Thank you. So the title, as you can see, is HRT Fundamentals in Women. Of course, 1 hour for this specific niche is almost impossible to cover. But I really don't want this to feel like a basic lecture about hormones today. In 1 hour, I want to show you why HRT is still denied, why it is sometimes done dangerously, and what modern safe HRT actually looks like. It's a common thing that patients as well as doctors are reluctant sometimes towards HRT patients because of the fear, because of what they are reading and hearing and so on, and misinformation is everywhere. And doctors, because they do not have a fundamental teaching, structuring, learning in this field, so they are afraid, kind of not confident and not sure about what to give to their patients. So my promise for this session today is simple. By the end of this session, I want you to think differently, not just which drug should I prescribe, but how do I reason safely from stage of the patient's life, timing of initiating HRT, risks for the specific patient, route of administration, which fits my patient in front of me, protection monitoring. And that shift is the foundation of everything we will discuss today. So before I tell you who I am, just picture a patient. Maybe you have already seen this patient profile in your practice. Like, for example, a woman, 52, and by the time she reaches you, she has already seen some doctors, let's say 3 doctors. The first put her on antidepressants for what he called stress. The second told her never to take hormones because they can cause cancer. The third one told her this is just menopause and she will get through it. Be honest, how many cases you have with these scenarios? A lot. Patient is exhausted, she does not sleep, her memory is slipping, she has a career, she has children, she has family. She's terrified that this is the beginning of something worse. She's not feeling herself, and she has already been failed 3 times by people wearing the same white coat. So she's in a waiting room right now. Let's see, she's in your waiting room. And the question today is not abstract, is when she reaches you, you will be the fourth doctor who fails her or the first one who finally gets her right. Think about that and think about how important your role could be in such patients. And this is the reason for this webinar. And for those of you meeting me for the first time, I am Dr. Raluca Hera. I'm a senior OBGYN. I am EU and Swiss board certified with a PhD from the Technical University in Munich. And my clinical work today for about 10 years now is focused on hormone therapy, menopause, also andropause, but today we're speaking about HRT in women, and longevity medicine. I practice in Bucharest as well as in Zurich. I have founded Hera Medical Institute, and I chair the hormone treatment committee within the Romanian Society of Aesthetic Gynecology. But I do not teach this because of my CV. I teach this because I see, like I said, for 10 years now, the same gap every week, every day. Too many women are denied HRT out of fear. Too many women are treated without a safety structure, and too many doctors are left to improvise. They are trying. They are trying, giving not maybe the right doses, not evaluating maybe the patient because they do not have an algorithm, they do not have a framework, they do not have a structure. And when you have the structure, it's really much, much easier. So my goal is to make you understand today that you can practice HRT safe, precise, and reproducible if you get the framework. So today's webinar, like I said, is only 1 hour, maybe 1 hour and 15 minutes, and it is definitely not enough to cover the HRT niche. So I'm not telling you what to prescribe today. I just want to show you how to think clinically about HRT and make this a starting point for maybe a new niche in your practice. So let me set the expectations clearly because this matters. This webinar, like I said, is a framework. It is a new way to think about hormones. And maybe some of you are already prescribing, some of you are maybe new, want to prescribe, but don't know where to start. So you will get the reasoning. The stage of the patient's life is very important. Timing of initiating of HRT is so important. Risks for the specific patients, always very important to evaluate. You will also get a concrete tool that you can take into your next consultation. So this is not a full dosing lecture. It's not a list of drugs to memorize. It's not a complete prescribing protocol today for every patient, because that would be unsafe and unrealistic in a 1 hour webinar. The protocols, dose logic, monitoring sheets, and real case supervision live inside the course and mentorship. So we organize a course, which is a 2 days course. We will explain details later, and a mentorship as well. And this is the framework where you would learn details. So today is only to build a framework. The protocols come later, and there is a reason for that. Today gives you the framework and one usable tool, and it's not a dosing lecture. Here's what we are going to do in the next 60 to 75 minutes. First, I will show you the clinical crisis, why HRT is still failed. Then I will give you the reasoning model, how to think, not to memorize. Then I will give you the practical tool stage, timing and risk. After that, we will apply to 3 patients that you will recognize from your own practice. They're classical prototypes. Finally, I will show you the training path for doctors who want to build this into a reliable clinical discipline. So this is not a random sequence of slides, it's a progression: crisis, reasoning, tool, cases, and next step. As you well know, in 2026, HRT is still denied, feared, and prescribed without enough structure. It is still denied when women who would benefit are turned away because of habit, fear, and outdated guidance. And maybe you can write in the chat if you have seen such cases in your practice, because I'm sure you have. It is still feared because the phrase hormones cause cancer continues to drive decisions more than individualized risk assessment. And even when HRT is prescribed, it is often prescribed intuitively. No clear algorithm, no monitoring discipline, and no documentation rhythm. And these are not empty words. These are exactly the keywords which you will be using in assembling a protocol for your patients and for your practice. So the problem is not that doctors do not care. The problem is that many doctors were never given a structure. And this is the core reframe for today. It is not only a knowledge problem, it is also a structure problem. So think about every process you are doing in your life. It's something you execute from A to Z in any field of your life. The same applies to HRT. You have to have the framework from A to Z in order to being able to be coherent and to be correct and to be responsible in front of your patient. Because what I see in the clinic is really matching some profiles which are really disappointing. There are, for example, 6 types of patients who keep arriving in my clinic. I have basically summarized some prototypes in order to give you an idea. I'm sure many of you will recognize these prototypes as well. First, the patient whose gynecologist never recommended HRT. So many cases. The second is the patient whose family doctor said, never take HRT, you will get cancer. And believe me, these are the patients who are the most delicate ones because they are the most difficult to convince after they had this opinion from the family doctor or from any other doctor, never take HRT because you will get cancer. It's so difficult to convince them, to convert them, to change their mindset to receive HRT after that. It's very difficult. The third prototype I am encountering in my practice is a patient already on HRT, received elsewhere, but still feels unwell because the route, dose, monitoring, or expectations are wrong. And I will probably get into details later on. Then we have the fourth case, the dangerous technical mistakes. Like, for example, I have seen transdermal progesterone given in a woman with an intact uterus who also receives estrogens. We have also patients refused because of comorbidities. That should have led to careful assessment, not automatic refusal, because 90% of the comorbidities go along very well with HRT. And not only that, but they also can improve with HRT. Their medication can lower, their metabolic profile is improved. So you should not deny these patients, of course, after careful assessment. And also we do have another type of patients who are reserved, frightened patients who need a lot of counseling for getting into the mindset of receiving HRT. These are also difficult patients. So this is why I repeat the distinction. Unsafe HRT is dangerous, but precision HRT provides protection and health over the years. So we can agree the problem is not menopause itself, but fear and lack of structure. So I would challenge you to short interaction poll, because I want this webinar to make practical immediately. So please type yes in the chat if you had even one patient refused HRT out of fear. If you have seen a woman who was told hormones cause cancer without proper risk stratification, type yes. And I will watch the chat for a moment. But what I want to tell you is that this is not a local issue, not a Romanian issue, not a Swiss issue. It's a general, a global issue. This is a global clinical pattern. Everywhere you go in the world, you can meet such types of patients. Why? Because we do not learn HRT in university. We do not learn HRT in residency. We just move through the practice years without knowing HRT. And at present, I must say, globally, there are such few doctors who are mastering HRT that they are really overwhelmed with patients. So a good practitioner on HRT is really a treasure. So you need to consider that to be one of them. Okay, so let me see what you answered in the chat. Yes, yes, yes. Okay, I haven't, but I have colleagues who don't want to prescribe HRT because of cancer fear. Yes, really, this is really typical pattern. Yes, many times. Yes. So it's unanimously, yes. Yes, exactly. Many of us have seen this. So the purpose is not to blame anyone. The purpose is to recognize that the problem is systemic. Once we recognize it, we can start building a better framework. And the fact that you are here at this webinar says a lot about you. You would like to be better, you would like to expand your practice. And why not to just keep only this niche in your practice, practice only that, because this can bring you a lot of patients, can bring you a lot of patients on a long time, and can basically help you, allow you to practice without having the worries of doing anything else in obstetrics, monitoring pregnancies, or doing surgeries, and so on. So it would be probably a much easier niche for you and much more rewarding. Okay, so I don't have any no in the chat. Let's move forward. So the fear around HRT has a history. I will not insist on this topic. I will just briefly mention the one study, one headline, and 20 years of fear. All of you might know about the WE study, the Women's Health Initiative study, which changed the global perception. Many clinicians and patients heard one simple message: HRT is dangerous because of this study. But the headline left out the variables that matter most. Look in this study, I will not go into details, the age of the patients in this study, timing of administration, of initiation of HRT, the route formulations, the molecules who were used, dose and patient selection. So different from what we're doing today. So the real clinical question was never simply, is HRT safe? That is the wrong question. The better questions are for whom is HRT suitable? When in her timeline? By which route and with what monitoring? This is so crucial when thinking about starting HRT in a patient. This is why modern HRT is not a yes or no decision. It is a clinical reasoning process. And if we continue to communicate HRT as one single risk category, we continue the damage that started 25 years ago with this oversimplified interpretation. This adoption curve is important because it shows where HRT is right now. For many years, the majority of physicians stayed away from HRT. But we are now in a transition period. So which is good. Patients are asking more questions. Guidelines are more nuanced and more permissive during last years. The fear is all starting to break, but trained doctors, as you see, are relatively few. That means that right now, being a physician who understands HRT properly makes a big difference. is a big differentiator. In 5 years, it may simply be expected. So I want you to see yourself on this curve. If you are here tonight, you are already among the doctors who recognize that the old fear model is not enough. The question is whether you will become a trained physician early or continue to improve while demand grows. Because in a couple of years, we will be here, hopefully. So this is not only a supply problem, it's also a demand problem. Your patients are already asking. The demand is already huge. They ask at least, doctor, should I be on HRT? What are you telling them? You can write in the chat. What are you telling a patient when she comes to you, let's say maybe for a gynecological checkup? But by the way, before leaving your office, she's asking, should I be on HRT? So what are you answering? They say, my friend started and feels amazing. They ask about, I don't know, patches, estradiol patches, for example. They ask whether hormones cause cancer. So that are questions who maybe you should know how to answer in order for an objective answering and in order for the patient to be good informed about what you are going to prescribe them. And that means the demand has arrived before the trained supply is ready. They are asking, but we do not have enough physicians who can really confidently, responsibly recommend them an HRT protocol. So your patient has two possible experiences right now. She either hears a confident, structured, medically responsible answer from you, or she's referred elsewhere, like I see a lot. Or she searches online or finds someone less rigorous. I see a lot of patients who are sent by their gynecologist because some of them don't tell them, well, HRT is not safe, but some of them tell them, go elsewhere to search for HRT protocol. The clinical opportunity for you and the professional opportunity are the same. Become a doctor who can answer these questions properly, and you will be a winner, in my opinion. And I'm talking not only to convince you to start learning about HRT, but I'm talking on my own experience. I have started this niche 10 years ago. It was context in which a patient came to me and put some bottles on my office. She came for an annual checkup, just like I'm telling you about these patients priorly. And she asked me to help her get these bottles, and she had bioidentical hormones. And I had no idea what this was about. And then I started searching, training, learning, and so on. And it became really a very important niche in my practice, alongside with cosmetic gynecology, which I was starting to do at that time because it started to trend. So now I have basically 80% of menopausal patients, and the rest is men and cosmetic gynecology. So this is what I am doing for the last 10 years. And that's why I'm speaking really out of experience, and I'm seeing so many people physically, but also online. So unsafe HRT is dangerous. That's, I can tell you for sure. Precision HRT is protecting. Is protecting, is sometimes life-saving, is promoting health and longevity. And this is not a slogan for me. It is really the clinical filter through which every decision must pass. If HRT is prescribed casually, without risk assessment, without a proper endometrial protection when needed, without monitoring, which is so important, without counseling, communicating to the patient, also crucial, then yes, it can be dangerous. When it is individualized according to life stage of the patient, timing, risk, route, protection, it becomes a tool for not only symptom relief, because this is only the tip of the iceberg, but also for prevention and for long-term health. So the shift is not only from an anti-HRT to a pro-HRT, but the shift is from lack of knowledge and fear or improvisation of a protocol to precision treatment. So this is the practical tool I want you to take from today. Before route, before dose, before product, ask 3 questions. This is where you start. First, stage of the patient. Where is she in the menopausal timeline? Is she in perimenopause, in menopause, early postmenopause, late postmenopause? Is she much younger, having an primary ovarian insufficiency or premature menopause? The second question you should ask is timing. How long has it been since her last period, or since she's in menopause? Is this within the window of opportunity for this patient? Is she under the age of 60, or is she within the 10 years of after entering menopause, which is considered nowadays the window of opportunity as per the actual guidelines? Or is this later? So this is a very selective decision on where the patient is regarding to initiating HRT. Window of opportunity is mattering a lot. And the third question you should ask is regarding the risks of the patient. What do you need to exclude? What do you need to stratify? And according to different problems of the patient, which I cannot go into detail right now, for example, cardiovascular risk, thromboembolic risk, breast cancer risk, and so on, we have frameworks to evaluate the risks, scores, which can tell us, is the patient eligible for HRT or not? Do we need prudence? Do we need a certain type of product, of molecule? Do we need a certain route of administration, and so on? What must I stratify? This is the third very important question before you think of an HRT protocol. And what must I monitor? Very important. If you remember only one practical thing from today, remember this: safe HRT starts with these 3 questions on your behalf: stage of the patient, timing, window of opportunity, respectively, and risk of the patient. Not what product should I give to this patient. This is not your first question. So you may take a picture of this screen, yeah. Next, we were taught to treat menopause as a moment. And it is indeed a moment because it means 12 months of amenorrhea. But per se, it is the start of a new life stage in your patient. So clinically, menopause is a process which starts on the day, on the moment where she hits 12 months of amenorrhea and moves onward. Menopause is not simply the date of the last period, it is the visible point inside a multi-year endocrine transition before and after this moment. Many symptoms begin, as you well know, before the last menstrual period. Because progesterone may decline earlier, yes, because she gets anovulatory cycles more and more. Estrogen may fluctuate before it falls. So the brain, the blood vessels, the bone, the skin, the urogenital organs, all do change. And they change progressively, and they change irreversibly. That matters because a moment has one treatment, but a process has a strategy for each stage. So depending the stage of your patient, you need a specific strategy and a specific monitoring protocol. If you misidentify the stage, you may overtreat or undertreat or treat the wrong mechanism. So before we ask ourselves, which hormone does this woman, this patient need? The first I would ask is, where is she biologically? What is her life stage? Make it very clear, because it's not always very clear. Let's say, for example, a patient who is wearing an IUD, a hormone IUD, and she's not menstruating. How do you know when she's entering menopause? But she still can get symptoms. So you need to really place the patient in the correct life stage. So we can agree that menopause care is not about naming a phase, it's about understanding the biological process. And stage of the patient changes the strategy. A woman with primary ovarian insufficiency, a very young woman, is not simply a younger menopausal woman. She has lost ovarian function decades too early. So our goal in this patient is restoration and protection against long-term deficiency. And the hormone doses are completely different than for a woman in real menopause, in natural menopause. Premature menopause also carries long-term risks that require a different level of urgency. In perimenopause, the main problem may be fluctuation rather than stable deficiency. So maybe these patients are the most difficult to adjust. The goal may be the stabilization of these patients, because one day they're good, the other day they're not good because their hormones are fluctuating. Then in menopause and early post-menopause, HRT may be initiated ideally within the window of opportunity, when benefits are generally more favorable, when we can discuss about prevention, when the modifications, the changes in all organs and systems have not been yet produced. Because as we know, we have receptors of estrogens, progesterone, but especially on estrogens and testosterone in each of our cells. So it's so important when we start to optimize and to stabilize the hormone levels as early as possible in order for preventing the fail of different organs and systems. And so the window of opportunity, like I mentioned before, is under 60 years of age ideally, or under 10 years after entering menopause. And then in later post-menopause, the goal may shift to careful stabilization. So if we start the HRT later in post-menopause, unfortunately, we cannot talk about prevention anymore, but about stabilization, symptom relief, and as much as possible, bone, brain, and vascular protection. But we need a stricter risk assessment and communicate clearly to the patient that if HRT is initiated after the window of opportunity, definitely still possible, she might not benefit of the prevention benefits of HRT, but the stabilization. So she might already have some changes, which we will see in a minute in a case I have prepared for you, which changes can be really irreversible or only partially reversible after initiating HRT. So same molecules we are working with, but different goals, different expectations, different outcomes. This is why stage must come before product choosing. So early and late presentation of the patient are not the same job. When a woman arrives early to you, meaning during the window of opportunity, while she's still inside these 10 years or under the age of 60, our goal is, like I said, prevention. We want to protect bone, vessels, brain, metabolic flexibility, and quality of life before decline becomes more difficult to reverse. And fortunately, we can do this because changes are not yet produced. The upside is higher and the risk profile is usually more favorable. When patient arrives late, the goal changes. We still may help, like I said, but we become more selective. And the goal is often stabilization, not the same level of prevention. Doses may be smaller, monitoring must be tighter, but foremost risk assessment before starting the therapy becomes more central. She needs to do a much rigorous evaluation. So the question is not only does she have symptoms, the question is, what job am I doing for this woman? What is my goal? Prevention, stabilization, or symptom control? It's very important. New study released a couple of weeks ago regarding cutoff of estradiol, for example, in the serum, just like a parenthesis, and related to symptom stabilization. And study says symptom stabilization, symptoms removal is not our goal in the HRT. Our goal is to achieve such a serum level of estradiol, which can effectively protect bones and vessels for cardiovascular protection. So important, but if the patient presents late, we might not be able to achieve these levels because they are too high for a patient who for such a long time didn't take hormones, right? So there are nuances. Same molecule, but different approach. So the window of opportunity is usually described as under 60 years of age and within 10 years from menopause, as per the National North American Menopause Society. And the latest issue of it is 2022. We're expecting the next one in 2027. And I would encourage you to read this guidelines because they are really good, very important in your practice. But I do not want to hear this as a rigid door, this window of opportunity, personally in my practice. Like a door that is either open or closed. We need to be flexible. So I am rather seeing this window of opportunity as a clinical variable that shifts the balance between benefit and risk and shifts my mindset in terms of evaluation of the patient and monitoring. Inside the window, for many symptomatic healthy women, the benefit risk profile is favorable, as per the actual guidelines as well. Beyond the window of opportunity, it does not mean that HRT is automatically impossible, like I said, but it means the evaluation becomes more selective and the goals become more realistic in terms of her already produced changes. So timing is a very important part of the prescription. Like I said, number 2 of this slide, which you really need to remember, stage, time, and risk. It influences safety, therapeutic objective, and communication. Timing of initiating of HRT is not a detail. It is a very important parameter before thinking about HRT protocol because it changes safety and strategy. And this slide is about the cost of delay. When a patient waits, nothing stays neutral. because all changes progress and they're not reversible. Bone density declines, as you may see. Vascular flexibility, elasticity, rigidity is on the way. Metabolic control is worsening, so metabolic flexibility becomes lower and lower. Genitourinary symptoms are also a very important issue, and they may become really chronic, bad, irreversible, and much more difficult to address. Sleep, mood disturbances may become part of the entire picture of the patient. But these are, like I said, symptoms of the tip of the iceberg, actually, but very important for her quality of life. So when we delay evaluation, we are not simply postponing the treatment, we may be allowing a biological slope to continue, so her degradation to continue. This does not mean every woman must receive HRT. But it does mean that every woman deserves a timely, structured assessment. The risk is not only acting too early or acting incorrectly. Sometimes the risk is doing nothing because we are afraid to reason clearly. Yeah. So we postpone. This is so often. One of the biggest issues in HRT counseling is risk communication. Probably you have patients who want a lot of information for you before taking a decision on HRT. Of course, there are a lot of information in internet. Now we have AI, and patients are really good, well informed, but they want to hear the things from you. They want to hear the facts from you. They want to hear what applies to them specifically, individually, personally, in order to get confident to start on HRT. Relative risk can sound terrifying if you communicate it to the patient. If I say something like breast cancer or any other thromboembolism or any other risk increases by 26%, patients are really very scared. They hear, "Ooh, danger." But if the baseline risk is low, the absolute increase may be small. So it's very important how you communicate the risk to the patient. Yeah. So in my opinion, and what I am telling to the patients is always the absolute risk. It must be explained before the relative risk. The second communication mistake is treating all HRT as one category. Oral and transdermal estrogen do not have the same metabolic and thrombotic implications, and you need to communicate that clearly to the patient. Yeah, because they are coming a lot from their family doctor, gynecologist, even hematologist, and they say, "Oh, I have a thrombophilia, I have a thromboembolic risk. I definitely cannot take HRT." But it's so important to communicate them, "Look, you are maybe more suitable." Of course, there are absolute contraindications in these cases as well. But let's assume she is not in that case. You need to communicate her clearly. "Look, this is oral estrogen, this is transdermal estrogen, this is the profile risk for oral, this is the profile risk for transdermal." It's very different in terms of estrogens, and also different progestogens do not have identical profiles. Synthetic versus bioidentical. Also, dose and route of administration matter, but you need to know that clearly and to know how to explain to your patient. Very concise, very clear, very convincing. So precision starts before prescribing. Again, it starts with the way we frame the risk and we communicate the risk to the patient. If the patient only hears fear, then she will definitely refuse the therapy. If she hears absolute risk, like 1 in 1,000, 3 in 1,000, something like that, which is not so frightening, Route of administration, like I said, oral versus transdermal, explained by you. Dose, timing, monitoring, she can really participate in a real shared decision. So communicating to patient is really very, very important. The root protection risk triangle. This is the second practical tool I want you to remember from this webinar. Maybe you also take a screenshot for it because it's so important. It's the root protection risk triangle. So before I ask what dose, I reason through three parameters. First, the root. Does this patient need systemic or local treatment? Should estrogen be oral or transdermal or vaginal? Can I or need I to reduce hepatic first pass effect by using a non-oral route? The second is the protection parameter. Does the patient have an uterus? If yes, the endometrium must be mandatory protected. What about breast cancer risk, cardiovascular risk, metabolic risk? All these need to be assessed before I think about what HRT fits to the patient. The third parameter is the risk. What is her specific risk? Thromboembolic risk, oncologic risk, cardiovascular risk. What is her metabolic risk profile? Very important. So, for example, a patient with migraine, obesity, VTE risk, or intact uterus is not managed by memorizing a dose. Yeah, she's managed by reasoning through this triangle. And I don't want to skip this triangle before thinking even what to prescribe to my patient. So not all HRT is the same. Root, uterus status, risk profile change completely the decision. I want to ask you a second question now. Type yes, please, in the chat if you have never had a clear system to reason from in HRT. Yeah. It's not a list of products. It's not what products can I find in my country. It's not a protocol copied from a colleague or copy and paste a prescription the patient had before. It's a real reasoning system. Like I said, remember this: stage, timing, risk, route, protection, monitoring. So a lot of things to cover before deciding this patient is or is not eligible for HRT. And if she is eligible for HRT, what is fitting her profile? So I want you to notice something. If you type yes to this question, I will look immediately what you have written. Does not mean you are careless. It does mean you were never really taught the system. So let me see what you did answer in the chat. Yes, 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 yes. Okay. So DVT, yeah, a lot of patients with risks you are also seeing. Yeah, that's amazing. Yeah, because globally menopause is manifesting the same under 60. The duration, okay. Okay, let me see what else did you answer. Yes, yes. So it is indeed, again, unanimous answer. HRT school doesn't exist, not even teach literally in books in med school. HRT was one line in the textbook. Yes, that's true. Yeah. It emerged during last years and yeah, late start, maximum age can start. We will answer these questions later. Okay, thank you for your answers. Now, here's one simple root decision rule you can use immediately. Yeah. So if the patient has systemic symptoms, hot flashes, sleep disturbances, mood symptoms, or you want to do a bone or cardiovascular protection, then think systemic therapy. Yeah, often transdermal when the depending on the risk profile. So, but there are certain cases when you can also use oral, but you will not fail with transdermal either way. If the symptoms are rather more genitourinary, like vaginal dryness, dyspareunia, urinary symptoms, you name it, there are a lot of symptoms, frequent infections, recurrent UTIs, and so on, then local vaginal therapy may be the appropriate starting point with minimal systemic exposure, very safe for the patient, even with a lot of comorbidities, and a targeted relief. This seems simple. Yeah, systemic symptoms, systemic HRT, local symptoms, local HRT. It seems very simple, but it prevents a common mistake using systemic therapy when the main problem is local and sometimes it's not necessary, or ignoring local therapy when systemic treatment does not fully address GSM, because sometimes it does, but sometimes it does not, and you need to add on. So again, the product itself follows the clinical need and the clinical reasoning. The route follows the symptom pattern and risk profile. Yeah, we need to really respect the order of the algorithm. So now I want you to be very clear about what we will not do today. I will not hand you a universal protocol to memorize. Maybe you will expect this, but it is really impossible. It would be unresponsible on my behalf, not because I want to hide information, but because that would be really bad medicine. So a protocol copied or two protocols or three protocols without understanding fails the moment the patient does not match the picture. Yeah. So real patients almost never match a protocol. You need to think an individualized protocol almost for each patient. Clinical reasoning is built, not memorized. So this is why I need a framework that really adapts, but you need to not skip steps in thinking how to develop an HRT protocol, because a copied protocol breaks 100%. So today we will build the framework, and later in the courses and the mentorship, we will build the implementation stage, dosing, logic, monitoring, adjustment, difficult cases, decision-making when the patient is not typical or simple. Now I will start to present you three real patients, three clinical cases, and we will move from framework to application. I will show you three patients. Each patient represents a different stage, a different therapeutic goal, and a different decision. So I choose three prototypes, and as we go through them, do not focus only on the treatment. Watch the reasoning behind the case. Ask yourself exactly what we have presented before. Ask yourself stage of the patient. So try to follow the algorithm. Stage, timing, risk. What is the goal? What must I exclude? What route makes sense for this patient? What must I monitor? So with these questions in mind, this is how HRT becomes really a clinical discipline. So let's take case one, which is a 43-year-old patient. She has insomnia and anxiety in perimenopause, and for 3 years, she has been told that she is simply stressed. This case is important because it shows one of the earliest ways perimenopause is missed. She is treating either for stress or not treated at all. She's treated for depression. She is treated for insomnia. But as a matter of fact, she has hormonal fluctuations due to perimenopause. This patient still has cycles. So nobody thinks about hormones, but the symptoms are already here. And let us look at how she presents. So she's 43. She has sleep troubles. She wakes at 3 a.m. She has anxiety, irritability, palpitations, some weight gain around the middle, around the waist. Her cycle is still present, but irregular. Because she still menstruates, she was told this is stress. She was prescribed some antidepressants. But when we look at the biology, we see a different story. We see a fluctuating estradiol. We see a very low progesterone. We see a borderline FSH, although not diagnostic, which is exactly what can happen in perimenopause. Yeah, because of course, other are the criteria of diagnosing really menopause. But in perimenopause, like I said, this is probably the most difficult life stage to adjust. And there are so many patients. And they are still young, they are having small children, they are having a career, they're having a family, they have a home to care of, and so on. And they need to care for themselves as well. And they are not able to do so because everything collapses. In perimenopause, normal or borderline tests do not exclude a hormonal transition. Keep that in mind. The biology is fluctuation. It's not a stable deficiency. So we might see normal values. So we should not treat only the label anxiety or insomnia and give her medication for these symptoms specifically. We must ask ourselves what endocrine pattern in her age might be driving these symptoms, anxiety, insomnia, palpitations. And here's the reasoning. This patient, Miruna, does not primarily need an antidepressant. She needs neuroendocrine stabilization. In perimenopause, the problem, like I said, is fluctuation of estrogens and luteal insufficiency due to anovulatory cycles. Progesterone may fall before estrogen is permanently low, so it's the first one who's declining. So the plan maybe in this patient might not be automatically full HRT in perimenopause for every woman. It might be targeted stabilization, maybe only progesterone. In her case, in this particular case, I would consider cyclical progesterone in the evening, starting with cyclical progesterone in the evening, especially because sleep is a key complaint. And depending on symptoms and evaluation, I might extend it to a continuously progesterone administration if her sleep is not improved. And then third stage, of course, after follow-ups monitoring, I would maybe consider a low-dose transdermal estradiol if needed. But you need to follow up the patient, see how her symptoms evolve, just not put her on a full HRT up front. I will reassess the patient around 6 weeks because the first question is what I'm looking for is her symptoms relief. Sleep improving, palpitations reducing, anxiety stabilization, and how the cycle is responding. Yeah. So in this patient, the take-home message is that her life will really change and did change in this particular patient because we treat the endocrine cause and not the psychiatric label. So in this particular patient, I had put her on progesterone, and then later on I had added, like 6 weeks later, I had added a low estradiol dose transdermal, and her life really changed. She got rid of the antidepressants, her sleep improved, her energy was back, and she was really another person. Another case I would like to share with you, also profile, prototype patient, is a classic menopause case, but with a common problem. She was refused HRT because of a comorbidity that was never actually an absolute contraindication. And this is where fear leads to undertreatment. Yeah, instead of asking, can I treat her safely and by which route? The previous answer was simply no. So let us look at the details of this patient, Claudia. age 49. She has hot flashes, night sweats, vaginal dryness, dyspareunia, low mood, low libido. She is already amenorrheic for 12 months. So clinically, she is in menopause, but she was refused HRT. And the reason why she was refused HRT was that she suffered of migraines. And some other colleague treated the migraines as an absolute contraindication for her HRT. But when we assess her, and really here with migraine, we also have specific risk assessment. But let the migraine apart, we assessed her also biologically. Of course, being in menopause, estradiol and progesterone were low. Her blood pressure and lipids were under control, were normal values. She is symptomatic. She is inside the therapeutic window. So the real question is not migraine, HRT, yes or no. The real question is what type of migraine, what vascular risk, what route of estrogen, what dose, what monitoring, what shared decision making, how to communicate to the patient that the migraines are not a contraindication for HRT and that her quality of life could be improved with by starting HRT in this life stage. So this is how we move from fear to precision. Well, sometimes it's not easy. Like I said in the first slides, if she's convinced by another doctor, that's very difficult sometimes to change. And here's the reasoning. Migraine is not automatically a reason to refuse HRT. It requires definitely careful assessment, especially if aura is also present. So migraine with aura is a special condition, or if other vascular risk factors exist. But HRT is not contraindicated, and the route matters a lot. In this patient, the transdermal route is important because it avoids first pass hepatic metabolism, offers a more favorable approach in terms of estrogen stability, and because this is considered a risk patient, a risk sensitive patient, right? And because she has an intact uterus, we need to add progesterone for endometrial protection. Because she also has GSM symptoms, genitourinary syndrome of menopause symptoms, local estrogen can be added for the vaginal and urinary complaints as well. So the treatment logic becomes transdermal estradiol, which is definitely the best option for a migraine patient, continuous progesterone for protection, and local estrogen for genitourinary symptoms. So the take-home message from this patient is the comorbidity she has does not exclude her from HRT. Yeah, the wrong route, like she's a young patient, it would have been really very easy to offer her some pills due to her age, due to the fact that they are much easier to administer. But the reasoning, the evaluation of the risks, and going through the entire framework reopened the door and exactly made the HRT treatment plan for her very specific, with no doubts. Okay, and now let's take a third case, which is slightly older patient, Elena, age 61. She's the late presenter. Yeah, she is in menopause. We will see in a minute, like for 10 years already. She has already cognitive symptoms. She's in late postmenopause, 10 years without hormones. And her daughter noticed some decline in her cognitive abilities and brought her to me with the real fear of Alzheimer's disease in her mother. This case is totally different from the first two cases. Here, we cannot think only in terms of symptom relief. Timing is later, risk assessment is more important, and the goals must be really more realistic and more carefully defined. Let us look at her details of this patient. She is 61. She comes with brain fog, memory lapses, low energy, low mood, and she, especially her daughter who brought her, is afraid of Alzheimer's disease. She entered menopause at 51. She has never used HRT. Now she already has type 2 diabetes and hypertension, which she is both treating. For 10 years, she was told hormones were too dangerous for her. So it's not that she denied the therapy, she was really not advised to take HRT. Her labs, of course, show very low values across estradiol, progesterone, and testosterone. With elevated metabolic markers, I will not go into details because there's no time for that in terms of her metabolic markers and how important they are for the cognitive function. This is the type of patient who must not be handled with the slogan HRT is dangerous or HRT is always good. So extremes are not available for these patients. She requires really clinical reasoning, a lot of prudence on our behalf, but let's try to optimize her and to protect her neurodegeneration. Let's try to optimize her hormonally, but also metabolically, because definitely her cognitive dysfunction is due not only to lack of hormones, so to atrophy itself, but also to the metabolic changes. Yes, we now know a little bit more about the pathophysiology of Alzheimer's disease, so that is so complex, but also treatable, reversible, especially in the initial phases. So we need to really assess her quite complex. So coming back to our basic framework, the questions are, how long since menopause in this patient? Yeah, when we think about what am I doing to this patient in front of me? So how long is she in menopause? What is her cardiovascular status? What is her metabolic risk? What are we trying to achieve with this patient? What do I want to improve? What route, what dose, what monitoring would be responsible? So here the reasoning is more advanced. This is a late start of HRT, so I do not act reflexively, like I reason very carefully in this case. The goal is not simply to remove the hot flashes, the goal is neuroprotection, cardiometabolic support, functional preservation, allowing the changes not to get worse, but within the limits of safety. After 10 years of menopause, her blood vessels are quite rigid, right? So it's really very important what doses we start with. So I would not start aggressively in this patient. I would consider low dose transdermal estradiol, progesterone in the evening, of course, because she has a uterus, cardiometabolic optimization alongside the hormone plan. So her comorbidities treatment should go parallel with my hormone therapy, and monitoring blood pressure, glucose metabolism, lipids, body composition, sleep, cognitive complaints, because you do a cognitive assessment first, then you do it again in 3 months maybe. All these become part of the treatment plan. This is also where you must communicate very carefully with the patient. We are not promising to reverse her symptoms, especially her cognitive symptoms. We might achieve them, but we do not promise that upfront. Very important part of the treatment plan is also the patient's compliance, the patient's discipline. Yeah, the lifestyle, all recommendations we are doing should be respected, should be followed. Otherwise, just a treatment plan on paper will not do magic. So this is why you cannot promise the patient, and we need to communicate with her very, very clearly what her tasks are. Yeah. So we are not promising to reverse dementia in this patient or cognitive decline because she's not having dementia yet. We are supporting systems that influence long-term brain and metabolic health and explaining her every adjustment we need to make hormone-wise and supplement-wise or metabolic-wise. So the take-home message with this patient is we are not treating her hot flashes. We are protecting her brain and function for the next decades with the treatment we are initiating. So let us put the 3 cases into one line of reasoning. Every case followed the same path. We have judged every case, evaluated every case through the same framework: stage, goal, excluding risk factors, stratifying her present risk, route of administration, and monitoring parameters. Yeah. So first I identify the stage, then I define the goal. Is it prevention? Is it stabilization? Is it symptom relief? Is it protection? Then I exclude contraindications. Then I stratify her risks: cardiovascular, thromboembolic, breast cancer, metabolic, bone risk. Then I choose the route and think about her protection. And then I think about a monitoring plan and an adjustment plan if such case. So there is, this is the difference between memorizing a treatment scheme and practicing on real cases. Can take a picture of the screen because it will guide you in your practice through all these very important steps so that you can take really confident, responsible decisions. So the real question is never only does she need HRT? It is stage, goal, route, protection, and monitoring. And why does this matter so much? Because one correct HRT decision can touch multiple systems at once. Yeah. If we choose a correct HRT, then we can target bone, cardiovascular health, cognition, sexual health, metabolic health. So this is why I keep saying HRT is not just symptom control, and it definitely is not. A woman may come in because of symptoms, of course, hot flashes, but the clinical conversation is much bigger than hot flashes. And of course, we must not overpromise. HRT is not a magic longevity drug. As a matter of fact, it is just a small part of a longevity protocol. But in the right woman at the right time with correct monitoring, it is one of the most important interventions in midlife women's health. So getting it right matters a lot. Getting it wrong costs more than a hot flash. So the molecules and brands differ from country to country because I have seen you come from all over the world. One country may have patches, another one can have gel, another has different progesterone options, another country relies more on compounded preparations. Reimbursement of the treatment also differs a lot from country to country, but the reasoning does not change. Yeah, stage, timing, risk, route, protection, monitoring. This framework remains the same. If you learn only brand names, your knowledge breaks when the formulary changes. So you need to learn the clinical reasoning. This travels with you and you will find the right product for your patient. This is also why the implementation call can be useful. We will talk about that in a minute. We can map the principles to your setting, your patients, and your country's available molecules. So safety is definitely the first thing we are thinking about. It is, of course, not the opposite of HRT. It's the way HRT is done. Contraindications define eligibility. Risk assessment defines caution. Monitoring defines discipline. Shared decision-making defines trust. And documentation, last but not least, protects both patient and physician. These are all parameters which we take into consideration also when we establish the treatment plan for our patients. Before starting HRT, I need to know who must be excluded, what risks are present, what adverse effects must be monitored, and how the patient understands her benefits and her risks. So I never want HRT to be a bold prescription. This is why the consultation for HRT is taking quite some time. Mine is 1 hour, maybe it's 1 hour, and then after finishing the evaluation is another 1 hour. So you cannot do an HRT consultation in 15 minutes or 20 minutes, definitely, because you need to communicate a lot to the patient, and you yourself, you need to evaluate rigorously your patient. So I want to make my a treatment plan very, very safe. And this is how we protect ourselves and also the patient. Yeah. Now I want to show you why the how requires structured training. Yeah. So you've seen the what, but the how is, of course, the gap. Yeah. We're now moving to see what exactly applies to your patient, your own country, your own formulary, your own comorbid cases, your own level of confidence. It's a different kind of work. And that is why this does not end with one slide where you see the framework or one protocol. This is the gap nobody filled, as you well mentioned in the chat. A webinar like this can give you the algorithm on a slide or 2 or 3 slides, can give you the hormone roles and risks, which we really definitely do not have time to enter into already past the time for the webinar today, can show you a few clinical prototype cases, but it cannot fully train you to reason through your own fluctuating perimenopausal patients or patients with comorbidities or patients in menopause or patients with breast cancer risks or patients with anxiety or migraine or obesity or bleeding or I don't know, patients in late postmenopause with late presentation. These are all cases you will encounter in your practice or specific cases you need to think really individualized. So I really cannot give you full confidence today in those root ratios, adjustment, when to stop the treatment, when to restart the treatment. There are so many things to discuss. But we have built the clinical reasoning, the framework, and the steps you need to follow in order to think about an HRT treatment plan. Okay. So this is where the course we have, of course, begins to make sense, not as more information, but as a structured way to build competence. And at this point of time, some of you may be thinking this is useful, but it's still too general for me to prescribe HRT safety and in every year patient, which is true. And if that is what you're thinking, you're absolutely right. A webinar is one too many. I don't know exactly what stage you are, what specialties you have. Maybe you don't know a lot of about gynecology, about menopause. Maybe you are already prescribing HRT. Maybe you are prescribing HRT for a long time and want to know what updates they are. So you are in different stages. This is why the information in this webinar is quite general. And your patients are really, each one doesn't match the other one. The distance between them cannot be closed by like another slide, which shows you what to prescribe. It is closed by structural training, real protocols, case reasoning, because HRT cannot be reduced to one dose or one slide. So safe HRT really requires clinical reasoning. And I am repeating again this framework I would like you to remember from this webinar. Think about what biological stage is my patient? How is she in terms of window of opportunity? What risk profile does she have? What route of administration am I thinking about her? Does she need progesterone protection, yes or no? What follow-up scheme do I do for her? Adjustment of therapy, communication to the patient, a lot of aspects we need to take into account. So if part of you wants more concrete dosing, more complex case protocols, or more really confidence to start confidently practicing in your office with these patients, more clarity or when to adjust, when to stop, how to stop. This is exactly why we build the course and the mentorship for you. So today we give you the framework, but the course really gives you the discipline and enables you to start working in this niche very professionally. These are two hesitations I hear most often from doctors. The first is, I might get it wrong. I have colleagues who say, I'm working with some products, but I'm always thinking, oh, maybe I get it wrong. And my answer is that is exactly why you need the framework. Yeah, because avoiding HRT does not protect patients when they need help. They need HRT, they need the correct HRT. And guessing does not protect patients either. So reasoning is what protects patients. And the second hesitation I hear in my from my colleagues who are whom I'm working with is this is not my specialty, or this is too late for me to start. But every reference physician was once a doctor who decided to start. We have a lot of physicians who really took the course, started practicing. Then we do have mentorships in which we are explaining cases. And this is how the confidence is built, and it's really never too late. So it's not it's not you becoming someone else. It is about adding a structured competence to the work you already do with midlife women. And why not become a specialist, an expert in this field? So the hesitations are normal, but it should lead to training, not to avoidance. So the program is built around two courses, beginners and advanced. The foundation is female HRT as a part of longevity medicine. But I want to be very clear, this is not just a course about hormones we are doing, it's a course about clinical thinking in HRT with the 4 values we are rigorously respecting in these courses, which are excellence, precision, personalization, and longevity, because we do also longevity integration along these courses. Because like I said, HRT is just one part, and nowadays we do have other parts to match other puzzle pieces in the longevity protocols. And our final goal is to deliver a longevity protocol to our patient, not only a hormone protocol, but this is another stage. Excellence means medical rigor. Precision means root, dose, stage, monitoring, repeating again. Personalization means no universal protocol for every woman. Longevity means we do not treat only hot flashes. We think about the next decades of the patient's life. This is the bridge from today's framework into the structured physician training. So the beginner's course, I will present them briefly, is the foundation. It covers female hormonal decline and menopause physiology, evidence, myths, and safety assessment before HRT, basics of estrogen therapy, basics of progesterone in HRT, and basics of testosterone therapy in women. Monitoring, follow-up, adjustments, longevity integration, and a lot of clinical cases. So I think this is a very useful course from A to Z to being able for you the next day to start practice HRT on your uncomplicated patients, which are the majority of them. Young patients in perimenopause or early perimenopause, healthy patients for whom HRT is definitely very safe and very healthy on the long term. Yeah, so this is for doctors who want to stop feeling uncertain and start building a safe structure. It's not a superficial course, it's very foundational. And it gives you really the language, the framework, the assessment logic, the first practical steps to understand HRT responsibly. And like I said, being able the next day already to start practicing it, because you will receive also a lot of templates, tools, which are already pre-built and which you can already print out and use in your practice. Yeah. So the beginner's course teaches you how to read the map in real clinical practice. The second course is the advanced course, and this is where we move. Of course, we have a slight overlapping with the beginner's course regarding some important notions in HRT, but we move more into complex cases and individualized therapy. It is more refined, more nuanced, and it is really for doctors who already practice HRT, because we will not repeat the foundations in this course. This is where we go deeper into evidence, current guidelines, diagnosis, indications, patient selection, contraindications, risk assessment, routes of administration in more difficult cases, bioidentical hormones, non-hormonal alternatives for patients who cannot take HRT, special populations, so special risk populations with exactly how to approach them, long-term management, discontinuation of therapy, emerging therapies, communication with patient, a very important and quite significant module, workshop of a lot of clinical cases, and of course, again, implementation templates for you to being able to start practicing at the next level in your practice the second day. This is a course for physicians who do not only want to start HRT, but want to manage difficult questions safely. So if you would like to start HRT, but also have patients with comorbidities or more complex patients, maybe it would be best to take both courses because they do not overlap. They overlap just very, very slightly. The advanced level is where you learn to think through exceptions, comorbidities, special populations, higher risk patients, complex choices, and long-term decisions. Yeah, so this is the difference between knowing HRT and practicing with really confidence and like an expert. So here's what you get. You get the recorded courses, so you can work through them at your own pace and return to the material whenever you need it. You get, so each course is about 10 hours. You get international accreditation with CME credit confirmed, details to be announced by my team. You get the clinical toolkit, like I said, already done, built-in templates, algorithms, lab interpretation sheets, dosage tables, questionnaires, informed consent templates for your patient. For those of you who invest in the complete package, you also get 5 live mentorships sessions, 1 hour each. This is where you can bring a real patient from your clinic or more patients, and we reason through the case together. And this is a small group of people. It is not unlimited, so that we can discuss each colleague's case. And you also get access to a physician community, of course, because this matters a lot, because HRT is not learned only from slides, only from courses, but also from experience, your own experience and others' colleagues' experience. So you can share your cases also in the community, get answered, discuss cases, and do follow-ups. And this is how we learn to become experts, through repetition, through questions, and through shared clinical thinking. So basically, the mentorship and the community, in my opinion, are what turn a course like this into really a discipline, a clinical discipline. So why is the complete package the strongest, in my opinion? Is the strong option because the beginner's course gives you the foundation, the reasoning, the safety, the core framework, and the advanced course gives you the complex cases, alternatives, discontinuation, and certification level implementation. The complete package gives you both courses plus the mentorship and physician community. That means you do not simply watch the training, you practice also clinical reasoning until it becomes like instinct, medical instinct for you. But again, some of you may need only the beginner's course, and maybe later on the advanced one when you get more experience and have more cases. Some already have foundations and need the advanced course only. But for many of you, the complete package is the most coherent path, in my opinion, because HRT is not a set of isolated facts. It is a discipline built in layers. Yeah. I just want you to show proof from doctors like you, just a couple of testimonials which are really true to reality, and they helped our colleagues who took the courses in their clinical practice as well, and consolidated the knowledges in the courses through the mentorships. Yeah. These are physicians who started where many of you are now. They were interested, they were cautious, they were sometimes afraid, they were sometimes skeptical, but aware that their patients needed better answers and wanted really to progress and to become experts in this niche. And please remember, there are not a lot of experts in the world doing this at a really expert level. So this is the transformation. Yeah, not reckless prescribing, not enthusiasm without safety. Please read through the testimonials. They are really very intuitive. So your transformation by taking the courses and by implementing these knowledge is really confidence, is structure, and is clinical reasoning. So the window is open twice. Your patient has a biological window, the years when the benefit-risk balance is often more favorable, like we have talked, and when intervention can protect what she still has. But you have also a professional window. I like this analogy. Right now, trained HRT physicians are still relatively few in many areas of the world. Patients are asking a lot, and it's becoming more and more increasingly the solicitations and the inquiries from patients regarding HRT. And a lot of colleagues are uncertain. They are having another activity in maybe OBGYN, endocrinology, family medicine, which they are dealing now, and they are already burned out and overwhelmed with those patients, and they maybe do not think about implementing something new in their practice. But this is your opportunity, in my opinion. Yeah. Because you can leave out that burned out activity and get into a niche where you are an expert, where you can also work less and be more rewarded, and have fantastic results. Believe me, spectacular results. And then when you have a patient, you have her for 20 years, 30 years, 40 years, and then she's bringing her friends and so on. So it is really, what I'm telling you now is really out of experience. So yeah, the doctor, I think, who builds this competence now can become the reference physician. You become a reference physician in your community. It's quite easy now at present. Later on, it will not be so easy anymore, because everybody will have interest in developing this niche because the demand is so high. Yeah. The knowledge will become more expected later on, like I have shown you on the curve. But right now, it still will differentiate you for years to come. So there's a window for your patient. There's a window for your practice as well. So I want to ask you a final question before we move to the next step. Type me if you want to be the reference physician for HRT in your area. Not the doctor who gives the same dose for everyone, not the doctor who avoids the topic out of fear, but the doctor whose patients say she was the first or he was the first who finally got it right. The doctor others send difficult cases to. Yeah. So answer me. So this is not just about interest, it's about your identity. To become an expert in this field, yeah, there are a lot of endocrinologists, there are a lot of OBGYNs out, but if you are an expert in this field, then you will be the one. Yeah, If you want to be that physician, the next step is not more passive information, but implementation. So let me see if you are curious. And I hope you are, because it is really, in my experience, thank you. Thank you for your answer. In my experience, a field which is, it is very, very interesting. It is very rewarding in terms of how you see the results on your patient and how she comes so changed, so happy. And then, of course, you will add on to being able to offer her a longevity protocol, not only an HRT. So the next step is not a checkout button, it's a conversation. You have seen the reasoning. So the question is now is not simply which package exists. The question is which paths fits your practice. Beginners, advanced, or complete package. Yeah. So we propose you a short implementation call where we can map your stage as a physician, your patients, and your country's available molecules to the right path in order for you to take a very good decision and an informed decision. This is why we propose this call. And because I do not want you to choose between beginners, advanced, and package. I do not want you to choose the same path, because each of you need different things. Some of you need the foundation, some of you need the advanced case reasoning. Maybe you are not decided on what you need. Yeah, some of you should enter the complete package because they want the mentorship. Maybe this is the missing piece. So yeah, I invite you to further on. We will have some more details, but I invite you to book the implementation call, which is just an informative call where you can be more clear about your needs and your perspectives. It is where we translate basically this webinar into your clinical reality. And let me set the expectations in this call. It is a 20-minute call about your practice. It's a conversation about your practice. It's a map of your stage, your patients, your country's products, and it's an honest recommendation. Beginners, advanced, or complete. So it's not a hard sell. It's not a pitch. It's not a commitment to buy anything. It's just a fit. If it's not a fit, we will tell you. So I want the next step to feel the same way as the medical framework we have presented today. So the next step I want to be presented as also structured, honest, and individualized. So if you have been thinking, I'm interested, but I'm not sure which course is right for me, this implementation call is, which is totally free, is exactly for that. And the process is simple. By design, first, you book through the link you will see and choose a slot. Second, you will speak with a team in a focused conversation about your practice and your patients. And third, the right path is confirmed on this implementation call. You will get more clarity and you will be able to take a decision. So you do not need to prepare a formal application for this call. Just bring the questions your own patients are already raising. This is very important to being able to evaluate you. And if you have also country-specific concerns, bring them. And everything I'm telling you now is basically arised from past webinars we have held and comments from past webinars from colleagues. So we refined this webinar and put everything together in order to come towards you with what concerns you might have. If you have a typical patient profile, bring it on the call. If you are unsure whether you belong to beginners, advanced, or complete, this is exactly what this implementation call will clarify. So we want the process to be simple because the work itself is already clinically serious. So it's a very rigorous course, and you should know what you take. They are, of course, a lot of colleagues who will tend to postpone the decision. For example, you think my patients will not pay for this. In many practices, even a small group of patients will invest. I am telling you this with the hand on my heart. Maybe they are not so many in the beginning, but they will be more and more in an exponential rhythm. Yeah. Because patients more and more want to invest in proactive expert care, niche care, not a general physician who can do deliveries and gynecological checkups and HRT and so on. No, they don't want that. And these are the patients who pay, and they are. So they need a doctor where they can trust in terms of this aspect of their life and their quality of life on the long term. Yeah. You do not need every patient. You do not need a lot. You need to become competent for the patients who are already asking. Yeah. Second thought for postponing taking these trainings is it is too complex to implement. And this is exactly why the framework and mentorship exist, and also the templates we are delivering. Because yes, it is a lot of information, but we try to organize it and to structure it so that you, the second day after finishing the course, will have some templates to start with. And then you add on, and then you refine, and then you will get more experience, then you will do your own templates. Complexity is not a reason to avoid the training. It is the reason to train. And another reason to postpone I have seen in colleagues is it is not my current focus. But your patients go through this transition, whether or not it is your focus. And believe me, if you are very busy with your current practice, like I say, already burnt out, you will never you will never have the time to focus on that if you do not do it on purpose, and if you do not have the image and the perspective of a vision of your future practice. So being ready is not by default. Yeah, it's part of the work you already do. So postponing feels safe, but time is passing. Patients are coming, and they're not getting a solution from you. So it does not remove the patient need, postponing. Yeah, patient need is huge. So learning to do this safely is not only a business decision. Your patients will go through these life stages, yeah, and starting even some of them from very young. You can take over a patient, let's say with premature ovarian insufficiency, under the age of 40, and then go with her along through perimenopause, menopause, and postmenopause. So a long time. So they will go through all these changes like bone loss, sleep disturbance, cognitive decline, genitourinary symptoms, metabolic changes. Whether you are not ready for them or are ready for them, patients are evolving in life and they are going through these changes. And it's better if you're the expert to know how to treat their problems. So being ready is part of the duty we already accepted as physicians. Yeah, this is the ethical frame behind this webinar as well. We are not adding a trend to our practice. We are closing a gap in care. And when a gap affects millions of women, learning to close is a professional responsibility. So is this for you? Of course, I will invite you again to book the implementation call if you want to practice HRT with safety and confidence. It is a free call, 20-minute call. If you are ready to change how you run your consultations, and if you want to close the gap in your training and lead, be an expert, then I totally encourage you to take this implementation call. Yeah, do not book if you only want a dosing cheat sheet to hand out. Do not book if you are not ready to change your practice. Do not book if you are shopping only for the cheapest option or the shortcut. Don't do that, because the course is really something very serious. Yeah, I say it very respectfully, but clearly this training is really for physicians who want to think better, or not simply collect another protocol. And if that is you, then the implementation call is the right next step. Now, brief information about the live mentorship, which is accorded to physicians, to colleagues who will invest in the package, the 2 courses, is limited. It's limited for a real reason to 20 physicians per live cohort. You cannot reason through a real patient cases with someone in a stadium, with a lot of physicians in the group, because I would like to share, so the live mentorships are with me. I would like to share specific details and advice and comments to individualized for the patient. And this is why we are analyzing the patient in close detail, and this takes time. And it's something very, very useful for you, for the others as well, but there cannot be a lot of people in the room. So we discuss your cases. Small groups allows real interaction, real clinical questions, and real reasoning through the complex cases, or even through the simple cases. If you are at the beginning and are unsure, we will sort everything out and go to through the framework together, this time on a practical clinical basis in the mentorships, as opposed to the course, which is more theoretically. Yeah. So the cohort is limited to 20 physicians per live cohort, and when a cohort fills, the recordings still exist, but the live mentorship seat may not. Yeah. So this part runs out after filled with 20 people. Yeah. So if mentorship to clinical cases matters to you, then you should really act quickly. Yeah. Now, also business-wise, let us look at the real math. A well-managed HRT patient is not usually a single visit. She's monitored over time. She may require, in the beginning, 2 consultations, then assessment, follow-ups, adjustment consultations, annual checkups, annual reviews, and integration with prevention in a longevity protocol. So one patient can represent significant value to your practice over a year, and even more, of course, over multiple years. And the exact number depends on your country, pricing, and practice model, but HRT consultations are not cheap. So this is a minimum we have calculated per patient per year. Yeah, this is why we do not solve the math generically on this slide, but it's a minimum we have calculated per patient per year. Yeah, but of course, in the implementation call, we can run it for your setting and see how does this look in terms of, so business-wise for yourself, for your practice. But the principle is clear. The training can repay itself, not only financially, so investing in these courses, but also in retention, referrals, and clinical confidence. Imagine yourself, for example, 2 years from now. If nothing changes, you may still be referring these patients away. You may still feel uncertain when one patient does not fit the pattern. You may watch another colleague become known as the HRT doctor in your area, but if you start now, 2 years from now, oh, you may be reasoning through comorbid cases, through complex cases with confidence. Your patient may stay with you because they finally feel understood and feel better, and their quality of life has changed. Other doctors may send you difficult cases, and the patients themselves will refer you other patients. So this happened to me. Like I said, 10 years ago, I was also starting in this field, and it really paid off. The difference between these two futures is not talent. It's not, I don't know, charisma. It is decision made earlier to build the competence. Okay, so I hope that today I have convinced you regarding these decision points. So this is the real choice. Booking the implementation call, 20 minutes or 30 minutes. If it's not a fit, you have lost nothing but 20 or 30 minutes, a short conversation. But not booking the implementation call, I think, in my opinion, is a disadvantage because you miss up on opportunities to know how your practice could evolve, how your practice can improve, yeah, and how you can become an expert in this field, yeah. Of course, no pressure, no pressure. But I think I would take this call in order to gain more clarity of what could I do more, where could I be, maybe if I don't have a vision on what this HRT discipline could bring to my practice. I think this implementation call would be very useful for you to gain more clarity. So if you want to explore whether these trainings, these courses are for you, I would definitely book this free call. So the bottom line is that it was never only about hormones, and it is never all about hormones in your patients. I used to say that it is about the next 30 to 40 years, maybe even more, of your patient's life. It is about whether she meets a doctor who dismisses her, frightens her, improvises her, or finally understands how to reason safely and improves her quality of life. Because patients don't know about bone density, don't know about cardiovascular, they know about how they're feeling, how their energy is, how they're feeling on a daily basis, how they're performing. This is what they want. But when you know the background, you know exactly where to push the buttons. So today you decide whether you want to be that doctor. So if the answer is yes to this question, your next step is simple. I encourage you, I invite you to book this implementation call and let us help you make the right training path for you and the right vision and picture of your practice 2 years from now. So I invite you to meet our certification team. So before we finish today, there's one final thing I'd like to share with you. Throughout today's webinar, we've covered a tremendous amount of information. We've discussed the science, we've explored the clinical reasoning, we've looked at real patient cases, we've talked about what modern evidence-based hormone replacement therapy can look like when it's practiced safely and systemically. But as I said also earlier, every practice is different. Every physician has different patients, different experience, different goals, different questions. And that's exactly why I don't want physicians making an important professional education decision based on a webinar alone. I want you to make that decision after a thoughtful conversation with people who understand your goals, your practice, and the patients you are dealing with. And that's why we've built a dedicated certification team. Their role isn't simply to explain our certification. They're responsibly in understanding your practice, answering your questions, helping you to evaluate where you are today, and determine whether this certification genuinely aligns with your professional goals. Leading that team is Benjamin Finnegan, our Director of Physician Consultations. Benjamin oversees every physician consultation and works closely with our certification advisors to ensure every physician receives thoughtful, individualized guidance. Benjamin, I'd love for you to explain what physicians can expect during their certification assessment.
All
Benjamin,
right.
take
Amazing.
over. Thank you. Hello.
Thank you, doctor. And yeah, thank you again to everyone who's spent their morning or early afternoon learning with us. That said, over the last hour, I'm sure I've been sitting here myself. You've gained a strong clinical foundation. And now, really, the question becomes, what does this actually mean for my own practice? And I see people asking, okay, how much does this cost? What do I do? Everything we do is custom to you. And so, what we don't want to do is give you some catch-all explanation. Instead, understand your practice and see, yeah, what what's really the best pathway for you. And that's exactly what the certification assessment it's designed to answer. And the purpose of this assessment isn't to convince you to enroll. Instead, our responsibility is to help you determine whether the program is actually the right step for you. And during this conversation, we'll spend time understanding your current practice, the patients that you're caring for now, the country that you practice in, the therapies that are currently available to you, and the question that still remains. And the goal in these conversations is for you to have your yeah, pathway clear. And once we understand your practice and the types of patients that you work with, then from there we can determine what implementation would actually look like in your practice. Because some physicians, they discover that, yeah, they're already ready to begin immediately, and others identify a few things that they need to address first before they bring HRT into their practice. Either way, both outcomes are completely appropriate. And because our goal isn't to help every physician to enroll, our goal is truly to help every physician that we speak to make the right decision for their practice. Now, we've we have a small team. There's only four of us, and we've reserved 20 appointments over the next 48 hours because today's education, it's still fresh in your mind. So the ideas are fresh, the questions are fresh, and yeah, we want to have individualized conversations with you. Once those appointments are filled, we'll continue scheduling physicians from our priority wait list. That said, uh, yeah, you already know from today's webinar that there's yeah, a door opening to something that you genuinely like to explore. And I'd encourage you to reserve a time while those appointments are still available. Now, um, I want to say that if today's webinar has changed in any way how you think about hormone replacement therapy, I'd like to personally invite you to continue the conversation with our team. Reserve a private certification assessment and come prepared with your questions. Tell us about your practice, tell us about your patients, and tell us where you hope you'd be able to go professionally. And together, our team will be able to help you determine what the most appropriate next step is. And if we believe that the certification is the right fit for your goals, we'll explain why. And if we don't, guess what? We'll tell you that too. So keep in mind that these sessions are not for bringing clinical questions or technical questions that would be better reserved for Dr. Raluca Hera herself. Instead, it's about helping every physician make the right decision for their unique practice. And You can reserve your assessment simply by scanning the QR code that's on the screen or by using the booking link that we're dropping into the chat. So yeah, the appointment only takes 30 minutes and it's a completely personalized to your practice. And at the end of the conversation, you'll have much greater clarity about where you are today and where your next step should be. So, Dr. Hera, I'll hand things back to you so that you can answer everyone's questions.
Great, Benjamin. Thank you so much. Thank you. It's very clear. And myself, if I were listening to this webinar and to your invitation, I think I would be the first to schedule the consultation, the call with you and your team. Sounds very good. And I hope, dear colleagues, you will, I'm sure you will gain a lot of clarity. Either if you decide to invest in the training or not, you will definitely decide more clarity on your pathway and your practice future, your practice perspective. Now, I will invite you to you may scan this QR code if you would like to book the call. Like Benjamin said, this is going to be repeated quite a few times during our question and answer session. I will invite you now to a 30-minute question and answer session. And I will take the questions from the chat. Let me see, or from the question and answers. So I am trying to figure out the questions. Thank you very much for all comments here in the chat. Thank you. I will not read them through.
Dr. Raluca, you can go to Q&A.
So you put the Q&A, right? I see in chat there are not so many questions.
I reply to them. I reply to all the
Perfect.
questions in the chat.
So let's take some clinical questions. I will not handle the logistic questions, the organizatorical questions, and so on. You will be able to place these questions in the chat, and the technical team will answer them. I will just focus on the clinical questions. So for a 42-year-old female patient with breast cancer, ER negative, BRCA1+, who has undergone a bilateral mastectomy and is also scheduled to undergo bilateral annexectomy, what treatment would you recommend? So she already had breast cancer. Would have been useful to know when this breast cancer was treated. Formerly, also receptor negative breast cancers are a contraindication for HRT for the first 5 years post-treatment. So you may opt for non-hormonal alternatives during this time, formally for relieving her symptoms, as well as local treatments. Take into account that she might have a local treatment for GSM with also with estriol if she is not taking aromatase inhibitors. Next question. Test, just 45 years with a regular period and having dryness, which bother her more. Yeah, it's nice because this is complementing a slide of our presentation today, and I will emphasize this again. So for local treatments, I will start with for local symptoms, I will start with local treatment in this patient. Yeah. Not systemic for the moment. HRT with fibroid patient and with a benign lump in breast needs to be evaluated. There's no contraindication of HRT for fibroids or benign breast disease. Very thorough evaluation. Go cautious with low dose, monitor, and you move forward. There's no contraindication. A patient in perimenopause for about 5 years. perimenopause for about 5 years that has a high LDL cholesterol. The last 2-3 years will normalize her LDL when taking HRT. So indeed, estrogen therapy has a favorable lipid profile, so can optimize, but don't rely only on estrogens to normalize her LDL levels. Definitely not. So the main, in first instance, the main treatment for LDL cholesterol high values is her lifestyle. So make sure that she adjusts her diet in terms of carbohydrates, especially in terms of intermittent fasting, in terms of number of meals per day, and quality of micronutrients, and make sure she's doing a lot of sports and that she sleeps well. So these are the main staples, and adding on HRT would be definitely a benefit, but it will not resolve by itself the raised LDL. I have a 36-year-old patient with primary ovarian insufficiency. She has migraine. Mother has, sorry, this jumped now. No new message came in, and the entire conversation jumped, but I'll go back to you. Okay, her mother has CVA at age 45, and a sister has a thrombus in retinal artery. Can she have HRT? So you need to do, of course, a risk assessment for this patient. Fact that her mother has CVA at age 45, of course, is not a contraindication for the patient. The sister had a thrombus in the retinal artery, is also to be investigated. Was that a spontaneous? What is provoked? What kind of thromboembolism it was? Nevertheless, it is considered a minor risk. In the training, we will have a specific risk assessment for thromboembolic risk, and then there you will be able to see all criteria that match or match not with an HRT. Of course, I cannot have detailed information about this patient, but primarily I would say she has no contraindication for HRT after a rigorous assessment herself. I have more of a human approach question. I'm a subspecialist in clinical immunology, but I do occasionally work in aesthetic medicine also. I have a huge problem with female patients even being able to grasp the idea about HRT. Women are so scared by old-fashioned endocrinologists, gynecologists, yeah, same story, telling them that they will get uterine cancer, cervical or breast cancer. I don't even have a chance to educate them on it properly, how firm it believes. I understand your concern, doctor. And maybe this is where, with proper training, you could add to your very interesting niche, which is complementing very good your, sorry, I have lost the Q&A. Sorry, which is complementing very good an HRT discipline you can do all together, and then you can incorporate more complex treatment plans in your patient. Nevertheless, communication to the patients is a chapter by itself. So you need how to deal with this communication. We are addressing this communication aspect with the patient as a separate module in our advanced training. So I cannot tell you now in 3 words what to say to your patients, because we analyze different scenarios in our advanced training. There's a separate module on patient communication with a test, which every module has tests after that. And then in the workshop, we also do scenarios, how to communicate to patients in different scenarios. So this is a chapter by itself. But I think this training, due to the specific practice you have, will very well fit to HRT, in my opinion. Let's see, a 51-year-old woman with irregular menstrual cycles, fatigue. Just excuse me 1 second. Should I stop sharing my screen? Maybe the technical team.
I already did. I already
Oh, okay,
notified you.
okay.
No worries.
Thank you, Diana. Okay, so in a 51-year-old woman with irregular menstrual cycles, fatigue, decreased libido, brain fog, carotid atherosclerotic plaque treated with chorus vera and sacroiliitis, what treatment would generally be recommended? Would menopausal hormone therapy be appropriate, and what additional investigations should be performed before initiating treatment? So she's 51, she has irregular menstrual cycles, not yet in menopause, fatigue, decreased libido, brain fog, carotid. So definitely HRT could be taken into account in this patient. I would go for transdermal in terms of safety for her other cardiovascular comorbidities. Of course, do a cardiovascular checkup evaluation. It should be recent. It should be a written medical report. Maybe you can do a medical board with a cardiologist and judge evaluate on the appropriateness of HRT, but definitely she will benefit from HRT. Her statin dose may even decrease. So I would encourage you to evaluate thoroughly the patient and move forward with HRT in her case. A patient 39 years old who has been experiencing recurrent vulvovaginal candida infections for approximately 2.5 years. Despite multiple courses of standard antifungal treatment, the infections improved temporarily but continue to recur. Relevant history includes recurrent vulvovaginal candidiasis for around 2.5 years, a recent vaginal culture, multiple courses of oral fluconazole. So you mean the patient 39-year-old. I would not say HRT is indication in this patient. The HRT has mainly 4 primary indications, of which recurrent vaginal infections is not one of them. She's a very young patient, doesn't seem to have any other symptoms, so you need to check you need maybe to check the cause and the pathophysiology and this recurrence elsewhere. Maybe she's a smoker, maybe she consumes a lot of sweets or has not a proper diet. Check her minerals and her vitamins and adapt and her metabolic profile, yes, in terms of insulin resistance maybe, and correct these aspects before thinking about an hormonal optimization, even locally.
By the way, just a short announcement. So we have over 25 doctors that already have registered. So we have limited spots for this course. So if you are interested, please book a call as well. Just wanted to remind for the other colleagues. Okay, we can continue with the questions. Thank you.
Yes, and the call is free, and it will be very empowering for you in terms of gaining clarity on what your practice can become and what an expert you could become in this niche. So really, I encourage you as well to book this call with my colleagues. 25 years old female with PCOS diagnosed at 13, obesity, had glaucoma. Okay, endocrinology, thyroid dysfunction, specifically autoimmune thyroiditis. Okay, and our consultant refused to treat the case, not even symptomatically. My question is, can PCOS be diagnosed at that age, and how do we deal with such cases? So as you well know, PCOS now is even not called anymore PCOS. It's called polymorphic endocrine metabolic dysfunction because it has been demonstrated, it has been shown that it's far beyond an ovarian problem. It's a metabolic problem. So these patients usually have not only a hormonal imbalance, but they also do have a tendency to autoimmune diseases. In this case, this patient already has an autoimmune thyroiditis, and it is very often in conjunction with PCOS, former PCOS. Also, insulin resistance, very important in this patient. Metabolic flexibility is low. So these patients formerly treated only with contraceptive pills should be rather more complex evaluated on a metabolic level, their metabolic status especially, and get optimized with according supplements. Yes, especially the insulin resistance needs to be addressed in these patients, which more often resolves also the hormonal imbalance when addressed. I would very much like to see the detailed lab values of this patient on all levels: adrenal, thyroid, insulin resistance, lipid profile, vitamins, minerals, their needs. In the majority of cases, these cases need a complex protocol. Although a patient is young, still, if optimized correctly, which is sometimes difficult to accept by such young patients. But again, communication with the patient also in these cases is so important. And sticking to a supplement protocol is highly important, essential for these patients. Nevertheless, don't neglect lifestyle factors. Also in these kind of patients and also with HRT. So lifestyle factors, which we'll also in detail present in the courses, is the foundation of your treatment plan. Yeah, this is the first and foremost thing to be communicated to the patient. And then we develop our treatment plan based on this foundation. So in this case with PCOS, also lifestyle matters a lot. And this needs to be communicated really in detail with the patient, not only do sports, eat healthy and sleep well. No, you need to detail all this with your patient. From another question, from a hormonal and endocrine perspective, what mechanism could explain recurrent candida infections in a woman like this? This is the same case. I think I have detailed this case previously. We will go to answer questions from other colleagues as well. Postmenopause with very low hormones, osteopenia, brain fog. HRT helps how to prescribe safely. So depending on which stage she is in perimenopause, if she's in early perimenopause, then you can right away start with HRT, which can stop progressing osteopenia. Sometimes in conjunction with other factors, like vitamin D, like enough protein intake, like strength training, it can also reverse partially her osteopenia, but you need to have a correct HRT dose. I don't know the age of the patient and time since she entered menopause, so that I can tell you more details, but you need to judge the case differently if it is an early postmenopause or a late postmenopause. Yeah. But definitely HRT will help in each case. But the framework is the same, like I mentioned before, just the doses probably will differ and the adjustments. Yeah, for osteopenia, you need normally higher doses, but you cannot upfront start with higher doses. You need to adjust them through the time frame of several weeks or maybe months. Patient 42 years old, inherited high lipoprotein A after myocardial stroke, irregular cycles, hormone levels, FSH6, AMH007 symptoms, fatigue, depression, mood swings, brain fog, hot flashes, very severe perimenopause symptoms. Can she have transcutaneous hormone replacement therapy? Cardiologist said rather no, but the patient is in real bad situation. So she already had myocardial infarction, as I understand. So here we need a thorough cardiological report. And cardiologists said rather no is not a satisfying answer for me as an expert in HRT. I need a more thorough evaluation, cardiologic evaluation, and a very updated point of view from the cardiologist side. You can then evaluate her globally as well. So myocardial infarction, she had when that myocardial infarction, doesn't say when, because it depends a lot on the on how old the myocardial infarction, how much time she has since the myocardial infarction as well. How the extent was, how her actual cardiovascular status is. Of course, you mentioned transdermal hormone replacement. In any case, if you would start on an HRT, transdermal would be the option, but I'm not sure she can have HRT in this moment because I do not have enough information from the cardiological point of view. What you can do in the meantime, before finishing her evaluation, is relieve her symptoms with non-hormonal alternatives. Again, the conversation jumped because I would like to know myocardia. Yeah, okay. So she has fatigue, depression, mood swings, brain fog, hot flashes. Yeah, you can start with a non-hormonal alternative for these symptoms. There are a couple of non-hormonal alternatives, which are very efficient for the vasomotor symptoms and for her sleep, for her depression. So you can start with that until you finish the evaluation. Maybe she's a candidate for HRT, but I don't know. I cannot tell you upfront for this patient. There are certain cases with myocardial infarction who are not good candidates for HRT. Women with hysterectomy should be prescribed all these hormones, all three hormones? And if so, is it better to start with the lower doses, even there are no ovaries also, or start with estrogen and introduce the progesterone after 3 to 6 months and testosterone after another 3 to 6 months? So formally, as per the guidelines, women with hysterectomy need only estrogen therapy, estradiol. Progesterone is not a standard it's not a standard product in HRT in hysterectomized women, and testosterone has as own primary indication for replacement therapy in women, the condition called HSDD, hyposexual desire disorder. So this is the only indication where we can administer testosterone in a woman. Nevertheless, testosterone is not a product indicated in hysterectomized women. So start with estradiol. If it is possible, I would like to ask about fezolinetant. So fezolinetant, for those who don't know, is a non-hormonal alternative for women with symptoms like vasomotor symptoms, insomnia, to sleep troubles. Do you have a personal experience prescribing this new medication? Maybe this is a good alternative for patients who had a cancer. Definitely it is the newest generation non-hormonal alternative treatment for women who have contraindications for HRT or do not want to take HRT for several reasons, but do suffer from VMS and sleep problems. It is very efficient. It is basically risk-free. It doesn't have adverse reactions like the other older generations products. And now they are studied some emerging therapies. Fezolinetant is an NK3 receptor inhibitor in the brain, and now other receptor inhibitors, more complex, working like this is a research similar to the GLPs. They discovered first the GLP-1, then the 2, now the 3. And as with fezolinetant, we have the same situation now, there are emerging therapies which are not standard now, which are targeting more receptors and are said to be more efficient even than fezolinetant. But fezolinetant, nevertheless, is very efficient. Studies are validating the therapy with fezolinetant for up to 12 months now, because it's such a new product and it hasn't been studied beyond 12 months of treatment. Can we prescribe HRT? And if yes, how, to patients who have thrombophilia, like Leiden mutation? So depending on the Leiden mutation, if it's homozygous, Leiden mutation is a formal contraindication of HRT, unfortunately. In terms of thrombophilia, there is a chapter, so I cannot detail now all other cases, but there are certain cases like homozygous factor Leiden syndrome, which is a contraindication. There are other as well. Otherwise, there are nuances in thrombophilia. Depending on the form of thrombophilia, we do have permission to administer HRT in most of the cases. What about patients already
Sorry,
with breast?
just wanted to congratulate the doctors. There are more than 40 doctors that register for the call. And I want to encourage you, the other doctors interested, to register for a call, because to see that if it's this course is appropriate for you and what type of mentorship it will be good. So this mentorship program, we are really proud of it. There are some doctors that posted something about some older courses that we had. This is a new course that we worked in the last 3 years for this. So it is it's something else that exists on the market, because we tried to put ourselves in the position of the doctors, from the beginners to the advanced, to see what our colleagues would need, what we needed when we started this kind of HRT treatments. And for doctors that ask if the peptide course is included in this, or the Dutch test, the course is included in this. No, these are different courses of ours, the peptide course, the Dutch test course. But this I recommend after you will do the HRT course. It will be much more easier to understand the Dutch course and the peptides course. So this is the fundamentals in the longevity program, that first we need to have something very clear, and then to build up so that you will be a specialist, a different type of specialist in your area. And you will see that the improvements that you bring in the life of your patients will be really amazing. Okay, so yes, it will be a certificate for today's webinar as well. And another question, we have CME points from Brussels. From the European, it's a European accreditation. So it's under the Romanian Society of Aesthetic Gynecology Association, but the points are from the European board. So you will be able to use the CME boards wherever in the world you can use them. So it's the International CME by European Accreditation Council for Continuing Medical Education. Okay, so this is about the points and about the certification for today. We will give you more details after we finish and all of that. Okay, continue. Thank you.
Okay, we'll continue for another 10 minutes. Is it okay, Diana, with the questions?
Yes, yes, we have a lot of
Okay.
questions. Yes, sure.
Yes,
Wait
yes.
10 minutes, so you can still in the next 10 minutes book your free call to discuss about what is suitable for you. We really want this course to be something that you use, that you need, and that it's useful for you and your practice. So that's why we need to have first this call to have an evaluation to see if it fits you, if it's good for you, and not just to buy another course, but it's a mentorship. It's something different. You will see. Thank you.
Okay, thank you for clarification. These very important questions you have answered. I have a colleague who asks, what about patients already with breast or gynecologic cancer with anti-hormonal treatment? So in terms of breast cancer, the guidelines are quite clear. First 5 years, you are recommended to refrain from any form of HRT formally, with the exception of local HRT. So topical treatment can be used, again, with the exception of patients on aromatase inhibitors. In terms of gynecological cancers, here the framework is not so strict. Depending on the gynecological cancer, they are pros or cons as regarding to HRT. And we do have a course, because Dr. Dumitrache, I think you are from Romania and you're speaking Romanian. We have a Romanian course on HRT and cancer. It's a short course which you can take, and there we are analyzing exactly, and we are giving you exactly the relationship of HRT with different forms of cancer, not only gynecological cancers, but all types of cancers. So it's maybe useful to look up into this course for you, which is in Romanian. A 50-year-old woman with class 3 obesity and a history of premature ovarian insufficiency, who has never received hormone replacement therapy, presents to the clinic. Can hormone replacement therapy be initiated in this case? Well, this an evaluation needed, first of all, with regards to bone density, second to cardiovascular and rigorous cardiovascular assessment. These are the main two risks with premature ovarian insufficiency or premature menopause. Now, if she would fit on HRT now, as I see, she does not have symptoms who classify in the primary indications of HRT, with the exception of her hypogonadism, but now she's already at the spontaneous natural age of menopause. So normally, one of the primary indications of HRT is hypogonadism, hypoestrogenism, early, like premature ovarian insufficiency or premature menopause, who needs to be treated at least until the age of 50 or 51, which is considered the natural age of entering menopause, which this woman has already arrived at this level where she theoretically could have stopped HRT. So it's difficult for me to tell if she now would benefit from HRT unless she really has symptoms. But her bone density is crucial. It could be a very good decisive parameter in assessing if she can start on HRT. Yeah, because if she already has osteoporosis, probably HRT will not do much. She would need specific treatment for her osteoporosis. Depending on her T-score, there are here also clear cutoffs where we speak about benefits of HRT versus benefits of specific therapies in osteoporosis. So you need to do an assessment, and then we can evaluate if she would be a good candidate, and of course a cardiovascular evaluation. And then a questionnaire would be also helpful in this patient. A questionnaire would assess maybe symptoms she did not tell you, she did not relate, but she recognizes them in a questionnaire. It happens to me very often that patients tell in first instance 2 or 3 symptoms, and then when they complete the questionnaire, they find out, and they even say that to me, I didn't even realize I do have these symptoms as well. So it's very important in this patient to give her a questionnaire to see what are her symptoms, and then after we have the whole picture, decide on whether she can start with HRT or not, if it would be beneficial for her. So thank you for useful webinar. Thank you too for participating. It's really an honor for me to having had so many participants today, and I thank you too. Now, excuse me, but again, as soon as a new question comes, the conversation jumps, but I will be back to the question. Okay, so I have a 40-year-old patient, had a premature menopause from 38. So this is a POI already. She does not want to use gels like Ginocadine. So it's in Germany, probably you are located in Germany or Austria. She wants tablets. What do you prescribe for her? And if you prescribe Femoston, which type do you prefer? She's slim. So yeah, after evaluating her risks, yeah, again, we go back to the framework. Just don't think about Femoston or Ginocadine. Just think about, is she a good candidate, and so on and so on. Just go through the risk assessment, contraindications, and so on. She definitely, if she's a good candidate, she's young, she probably is healthy, she definitely needs an estrogen. Preferably in these patients, I am looking for 17 beta estradiol, so for a bioidentical estrogen, because this is the hormone who sticks to the receptors on the bone. Any other synthetic estrogen would not go and stick to the receptors on the bone, so she would not have benefit for her bone density with synthetic estrogens. She would have a benefit for other symptoms, but not on the bone, which is very important for this condition. Yeah. So go for a natural bioidentical estrogen. And now you ask if it should be a continuous or a sequential regimen. This is basically what you are asking in terms of Femoston, which type. So here it depends on the patient's preference. If she still wants to menstruate, then put her on a sequential. If she doesn't want to menstruate, then put her on a continuous scheme. So it's not a preference here, but the estrogen type is very important in these patients. 55-year-old patient, when given HRT, are we expect bleeding? Is it normal, or we have to stop HRT, do biopsy? So she's bleeding on HRT. Again, very important to go through the framework. When was the HRT initiated? There are several months after starting HRT. When was she, what life stage was she when HRT was initiated? Was she already in menopause? Was she still menstruating up once in a while? It's very important, her life stage when HRT was initiated. And then there are several months after initiating HRT where some bleedings can occur. And if you did a correct evaluation before, a pre-assessment correct evaluation before initiating HRT, and she was okay, nothing dramatically could happen in 1 to 3 months. So don't rush for a biopsy. Just look up if the doses are correct, matched, the ratios are correct. Maybe do some levels in blood to see if they are matching. Maybe do a vaginal ultrasound if you are worried, but don't rush with a biopsy in the first month. But if she's taking HRT for a longer time, more than 6 months, everything was fine, and then suddenly she started bleeding, then another evaluation is important. So again, we're going back to this framework we have learned today. Just don't think in terms of what she's taking, a molecule. Just think the entire framework step by step. And then everything will be very, very clear. If there is no transdermal estrogen and progesterone available in the country, how to proceed with therapy? I don't know what country you are, but progesterone transdermal is really not an option with intact uterus, so you don't have to worry if you don't find transdermal progesterone. In terms of transdermal estrogen, if you are located in the European Union, even if it's not available in your country, your prescription is available throughout the European Union, and the patient can purchase a product from another country with your prescription, which is valid in the European Union. If you are not in the European Union, maybe this needs to be also makes sense to clarify that with our team during the call. They will take your specific questions, and we will analyze them and go through them and answer your questions and find a suitable answer for you, because I'm not familiar myself with all countries in the world. I am very familiar with European Union, with Switzerland, with the United States, Australia maybe also, and South America. So I might not cover all territories, but our team will be definitely happy to help. Can dermatologists prescribe HRT? If you have a certification, I don't see a problem. not to prescribe HRT, depending on your country, depending on the curriculum in your country. If you can add a certification of this type on top of your expertise, of your dermatology curriculum, then I don't see an issue. But depending on the country and on the curriculums which are accepted there. So I think there are far more questions. We will not be able to answer them all. We are slowly approaching to the end. Maybe we can, I don't know how to proceed, Diana. There are a lot of questions to take them over and try to answer them otherwise, because it will take us probably 2 hours more to answer these questions. I really hope you found this webinar useful. I also had, but I'm not sharing my screen. I also had a contact slide with my credentials. If you would like to reach out, please feel free, but I'm not sure I can
I can allow you
now. Okay, thank you.
because some doctors here they said they are interested to become patients. And so,
Thank you. I will just briefly put my credentials, so my email basically, and please feel free to reach out. So here, yeah, here it is. So thank you once again. Now, sorry, we are late. We have
yes, it's almost like 3 hours, I think, right?
yes, yes,
Okay,
yes.
we
But I
were.
hope you found every
Yeah.
information useful. I hope you find the information really inviting you to explore further. And I will be more than happy if you would book a call with our team, who is really willing to help with further decisions and very professional. Thank you very much.
Yes, thank you all for being here. It was we were thinking to have about 1 hour and a half or 2 hours, but because we had a lot of questions from you, this shows that it's a lot of interest, both from the doctors and from the patients, right? You have a lot of patients asking you about these things. So I congratulate you for spending 3 hours of your Sunday with us and not your children or outside. This means that you really want to invest in yourself and you want to be better every day because, you know, in medicine, everything changes from day to day. So it's important to be in touch with everything is new and to be, you know, that special doctor that everyone says, oh, I need to go to that doctor because he or she knows more than our other colleagues. So thank you for being here. I encourage you to go to our team and to choose the course that it's appropriate for you and it's right for you. And hope to see you in our online courses. Thank you very
And
much.
again,
Have a
you're
lovely
adorable.
Sunday.
Bye.
Bye. Bye bye. Thank you.
Bye bye.